Most people don't understand when you say hunger. No one's hungry in this country. You know, this is the land of plenty. What we found in our interviews with people, when we ask, have you ever been hungry? They say no. But if you ask, have you ever skipped a meal? The answer is yes. Have you ever had not enough to eat? The answer is yes. Have you ever gone a day without eating? The answer is yes.
The number of people in Memphis who don't know where their next meal is coming from is eye-opening. According to the organization Feeding America, 17% of households in Tennessee are food insecure. That puts our state as one of 12 in the country with higher than average rates of food insecurity. In Shelby County, the problem is greater. Over 20% of the total population is food insecure. The impact of food insecurity goes far beyond mere hunger. Statistics from Feeding America show that 60% of food insecure seniors are more likely to experience depression. 53% are more likely to report a heart attack. 52% more likely to develop asthma. And 40% are more likely to have congestive heart failure. It's estimated that food insecurity adds $160 billion to the cost of health care in this country every year. In 2015, the Plow Foundation's Aging Initiative awarded a grant to 8 agencies in the Memphis area to develop the No Hungry Senior Project. MIFA is the lead agency in this collaboration. Floria Robinson is a No Hungry Senior client. She receives a weekly delivery of shelf-stable foods from MIFA volunteers. Each box contains food for 7 meals, 4 breakfasts and 3 lunches or dinners, plus some snacks. The total cost of this box is $9.50. As of March 2018, the No Hungry Senior program has served 1,750 clients since the program began. Over 500,000 meals have been served. Demographically, No Hungry Senior clients are an average of 76 years old, African American females, with a third of them living alone, and half of them living on less than $1,000 a month. Currently, the program is serving 980 clients, but the future of their meal deliveries is in doubt because the No Hungry Senior program is only funded through the end of 2018. To find out more about what happens next, I interviewed 3 representatives of the No Hungry Senior Collaborative. Well, this is the 4th year of the Plow Foundation's grant. For a moment, just step back from the program. Give me the big picture of now into the 4th year of the entire program. Where does it stand?
Well, of course, we're very grateful to the Plow Foundation for this grant to meet this great need in our community. It was always about helping to serve seniors at the highest risk of food insecurity. MIFA had had the Meals on Wheels program since 1976, but we knew we weren't meeting the need. There was still an enormous gap, and the need in Shelby County, we estimate there are over 4,000 seniors who could really benefit from home-delivered meals. And the need in Shelby County is so great because of our high poverty rate, the number of seniors who live alone, and the aging population is growing. So over the course of the program, we have been able to serve an additional 1,700 seniors, and that means 500,000 meals have been served over the years of the program.
Now, this is a collaborative effort. As a matter of fact, we have 2 of the collaborators here, but who's been involved in this? How has this collaboration worked?
From the beginning, it was important that this program be collaborative because we wanted to learn from partners, and we knew the more hands and the more minds at the table, the better we'd be able to meet the need and the more we would learn. So there was a long period of planning and just meeting before we really actually began service. And our partners include, we're real excited, the 2 major healthcare systems, Methodist Healthcare and Baptist Memorial Healthcare, the Aging Commission of the Mid-South, who refers clients, the Mid-South Food Bank, who helped us with our shelf-stable meal service, The Catholic Charities helped with volunteers, the Jewish Federation, Jewish Community Partners, the University of Memphis School of Public Health, who has served as our outside evaluator, and Co-Action Net provides our database.
So a considerable number of contributors to
Yes.
this program. Tell me, what does a typical recipient of this food look like? Can you draw me a profile?
Sure. 61%, your average client is female, African American. So about 61% are female, and about 70% or more are African American. The 33% of them are widows or widowers. And the majority, over half of them actually live on less than $1,000 a month. The average age is about 76, although we have had seniors who were over 100. We had a 106-year-old gentleman who was in the program. And we had about a third of the participants are over 85, so they are elderly. A lot of them have health complications, so we all know that hypertension and diabetes are common in the Mid-South. However, it's really common among this population. 82% have hypertension. And I think of the diabetics, I think it's about 45% have diabetes. So getting meals that are nutritious and that are low sodium, it's really important.
Do any of those figures about the profile of a typical recipient, do they surprise you in any way?
Not really.
No?
No. I think because, as Sally had said, our aging population is growing and that we have such high poverty rates here that, no, it's not surprising at all.
Now, you mentioned the Aging Commission. I know the Aging Commission has a waiting list.
Mm-hmm.
They've had a waiting list year on year on year. Have you been able to make a dent in that waiting list with this program?
Yes, the size of that waiting list was one of the an impetus for this grant to begin with, because compared to other areas in the country, our waiting list was so enormous. So when we began, I think they estimated their waiting list was at about 3,000, and today it's closer to 1,200.
So you've been able to make a dent,
Mm-hmm.
but there's still a lot left.
Right.
Plus, more people are being added to that list.
Right,
Okay.
right.
You mentioned elements like disease.
Mm-hmm.
Let's talk about the fact that this is more than just about food and eating and being hungry and satisfying hunger, because there's an emotional component to this, and there's also the physical component. So talk a little bit about how a program like this affects people on that emotional and health level.
I know in the hospital, I work for Methodist Healthcare, and patients are so appreciative of having a stable source of food. A lot of them, like you said, are alone. They have difficulty preparing meals. In fact, I have an example. Mr. Jones is an 80-year-old gentleman, and he was admitted to Methodist last December. Multiple falls. He had a history of diabetes, stroke, and when he came in, he was considered by insurance to be too high functioning to qualify for a skilled nursing facility. But he was also in too poor physical condition to go grocery shopping or to prepare meals for himself. And so this program really offered him the opportunity to get the nutrition that he needed, and to have some interaction with people who were delivering the meals. And he started on that program in January when he was discharged from the hospital. He has not been readmitted since.
But speaking of that, what's the significant data you're seeing for the program so far?
Sure. So we looked at the main outcomes we wanted to see were did getting this food service improve health, or at least maintain health of these seniors. We didn't expect to see vast improvements, but we wanted to make sure that people were able to feel better, to have some health maintenance, and to be able to stay in their homes. So those were some of the things we wanted to look at. So when they enter into the program, they get a full assessment in terms of their nutritional needs, their social support, their self-perceived health, the numbers of times they've been in the hospital or gone to the emergency room. We ask a range of questions. And then every year at their anniversary of entering the program, we do a reassessment. And then we also do a satisfaction survey. And so what we were seeing from the numbers pretty consistently from the second year on was that the seniors were reporting less hospitalizations, and they were reporting less emergency room visits. And so that looked really good to us. They were also reporting less loneliness because we use a loneliness scale to assess, whether or not they are lonely, and less loneliness. So we thought this looks really good, but this is self-report, and sometimes people don't remember events, and so we really wanted to find out, how accurate that was. So fortunately, with Methodist as one of our partners, Methodist said that, we could look with them at their data to see that. So we looked at about 225 patients who had been referred by Methodist into the program, and we looked at what their healthcare utilization was before they entered the program, a year before they entered the program, and the year after, that they entered the program. And what we found was pretty startling, because it actually confirmed what the clients had told us themselves. There really was less utilization. We looked at the data, and for every month that a person was in the program, their healthcare utilization declined. So it was a nice, solid slope, a downward slope for that. And also the utilization costs. So also for every month in the program, utilization costs went down $345. So we're saving hospitals and saving Medicare money by providing food to these seniors.
Now, correct me if I'm wrong, but this is the kind of data you were never able to achieve as MIFA or as the Memphis Food Bank or anyone. You don't have access to that kind of data, do you?
Right. It was important for us to build evaluation in for part of this project, but really exciting that the partnership with Methodist and the collaboration made this possible. And we're really grateful because Methodist, this was an add-on. They just, got interested in the program and as a partner and said, well, let's take a deeper look. And so 3 years in, and we're able to see some significant findings.
Give me some details on how the healthcare systems, Methodist in particular, how does it integrate in, how does it fit into this program? How does it work?
Well, it's another team effort. Our great nurses will screen our patients for us for nutritional risks. So things like unintentional weight loss, decline in appetite, being underweight, or having pressure wounds when they come into the hospital. And when they find those things for patients who've been admitted, they consult the dietitian or the diet technician. And we go and interview the patient, and we do a food insecurity screen. So we'll ask them 10 quick questions to determine if they are food insecure. And if they meet those criteria, we offer them this program. We
so
get
you're
their
actually
consent.
identifying people in the hospital setting.
Exactly.
And then tending to them. Is there follow-up after that you have, or?
Right. So we, before they're discharged, we have these great grocery boxes that have been provided by the food bank that contain 7 shelf-stable meals. And so it's kind of a bridge until MIFA and the food bank can start providing meals as well.
And did I hear you say earlier that it's had an impact on hospital readmissions?
It has.
What has been the impact?
We've had decrease in emergency room visits, decrease in length of stay, 30-day readmissions. When the patient returns to the hospital, if they do return to the hospital, we have less incidence of fall, and the patient is more weight stable.
Now, I understand that you're partnering with Methodist for some more information, additional information to what we just talked about.
Well, and Deb may speak to that, but this is the research that this is part of the research that we are seeing.
Right. Yeah, so as Allison said, there's been decreased inpatient admissions. And when we looked at the data, I think I mentioned that we looked at a year before they entered the program and a year after. So there's a 34% decrease in inpatient admissions compared to if you take any given patient, before and after. The average for those patients is a 34% decrease in admissions. So, and that's, what we were hearing from the patients themselves.
Significant number.
Mhm.
Well, this you're in the 4th year of the Plow Grant, and the grant ends at the end of this year. So what happens next? What happens next year?
Yes, as all grant funding does, it will come to an end. So we are really focused on sustaining the program and sustaining service to seniors. We hope this data will help us attract future funders, because it shows very clearly the impact of the program, and that something as basic as a meal, as basic as a volunteer checking on a homebound senior can make an enormous difference in that senior's life. We also are building on the program in that we're looking at other things, other ways we can impact these seniors. For instance, you talked about loneliness and the fact that our seniors say they are less lonely with this program, and we thought, well, how can we do more? So this fall we'll be launching a program called My Phone Buddy, and we will pair volunteers with some of our homebound seniors, and those volunteers will make additional calls and safety checks. It will be really helpful to us during inclement weather, because sometimes we're not able to get out, and so that volunteer can call during that time. So we want to continue to invest as we are able in the program and build on the data and continue to do that. But the most important thing is what we can do to continue to serve meals to these seniors, because we don't want the waiting list at the Aging Commission just to go back to where it was previously.
Now, big picture, you've made a dent. All of your efforts, the No Hunger Senior Program has made a dent, but what would it take to put an end to food insecurity among the elderly?
Well, I think we probably all have some ideas on that, and I think it would continue to be a collaborative approach from healthcare, from the nonprofit community, and then also from our government programs. Meals on Wheels is funded through the Older Americans Act, so we're concerned that that funding remain. It has been a level, which in essence means declining because the need is growing. So, we watch the funding for that program very carefully and always hope that there might be increases to that. SNAP, there are other programs that are very important for food insecurity.
No, I think it is going to depend on continued federal funding. You really can't ask communities to do all of that work. And as Sally said, it's not an expensive program, but it results in very significant cost benefits. And so I think if they look at that from from Medicare standpoint, it results in cost savings for Medicare. So I think they have to look, I think our legislators need to look at a bigger picture and not just at this individual program for funding meals. They have to see what the impact of it is.
Well, I'd like to thank all of you for being on The Best Times, talking about this important issue of food insecurity among the elderly. Thank you.
Thank you.
Thank you.
Thank you.